at Ollington Road. Next door, I have Nikita and Kate who are working with us. But my side trade is in dermatology, and I do this and have done this for a number of years. And I run a clinic here in the community and work very closely with the dermatology department up at the hospital. I've been asked to host this talk to hopefully give you just a few useful tips regarding a couple of areas of dermatology. It's extremely vast to cover in an hour, so I'm hopefully going to give you some tips that might help you in your day-to-day job, also just socially with family and friends, and perhaps your career may lead you down the path of general practice, and certainly what I am presenting often begins its journey through the doors of a GP practice. And if I can give you some tips at that point, then hopefully you'll be better enthused for dermatology, which I know, I guess, doesn't get covered so much at medical schools these days. So the areas I want to cover when it works are essentially moles, which quite frankly are probably the biggest and urgent problem in dermatology, more so than anything else. Of course, you have your rashes, but speaking about dermatology in general practice, these are probably the ones that you don't want to miss more than anything. And I want to give you some tips on recognizing which lesions are going to be benign and which ones are going to be malignant, and hopefully help you guys pick up on those sooner rather than later. And I do remember, even on the wards, when you're listening to chests, even in A&E, looking at swollen legs, you will occasionally see moles or warts or lesions and think, oh, I wonder what that is. Do I need to do anything about them? So hopefully that will help you out even in your day-to-day job. The other thing I want to talk about is acne. Very common, but often gets neglected, partly because patients don't worry so much about it. But even if they do, sometimes they don't get referred until it's too late. So I just want to give you some tips on that as well. And then finally, a little bit on eczema and psoriasis, mostly how we can spot the diagnosis. Sometimes it can be difficult. And some techniques and tips on how to manage it, hopefully again, which will aid you even on the wards, particularly those old swollen legs, lots of dry skin, that are red, query cellulitis, when actually could it be something else like an eczema? So hopefully that will be, we'll have enough time to cover all three. So the first thing is whether we are dealing with a mole that is benign or malignant. How can we recognize the difference? Now, normally, when I'm in front of you, I get you guys to tell me which ones you think out of these 4 images are benign and which ones are malignant. I'm aware, of course, we can't do that. So just consciously in your own minds, have a think, have a look, and just ask yourself which ones do you think are benign and which ones do you think are malignant. And you'll see, just to give you some tips, that we've got color, shape, size. They're all slightly different. But the truth is, they are all benign. And in fact, this one, the one on the left, was one on my arm. So I do hope it remains benign. It's still there, hasn't changed. Now I ask you the same question with these. I think you can see a notable difference in all 4 of them. Again, shape, color, size, all very different. They just immediately look wrong. I think even if you were a member of the public, you'd be looking at thinking, oh, what's going on there? And all of these are malignant. So let's have a look at these ones. These are slightly trickier. You've got 3 images of moles. You've got small moles. Again, shape, size, color. Harder this time. I think you'll agree it's not clear. And indeed, actually, all 3 ended up being cancerous moles. So how do we spot those ones that are slightly on the fence? What's going to help us differentiate between what's obviously harmless and what's obviously malignant? So you may have read or heard already about A, B, C, D, E ruling, and using that to pick up on possible melanomas. And that's what it aims to do. This ruling, which I'll show you in a minute, is trying to differentiate between the harmless ones from the melanomas and the lentigo malignas, which are a precancerous melanoma. And it follows these rules. We look at the symmetry of the lesion. A symmetrical lesion, just like the ones on the left there, and in the images we saw at the beginning, is the same all the way through. The colour, the shape. The borders are very important. A well-defined border, by that I mean you can draw a ring around it. Usually is a good sign. But if you can see on the right, the irregularity, very hard to draw completely around it. It's clearly not normal. The colour, well, we saw those in the very obvious melanomas in the images before, but shades of colour, particularly 2 or more, particularly browns and pinks, are a concerning feature. Size is very important. Anything bigger than 6 millimeters needs to be treated cautiously. I will warn you, not everything bigger than 6 millimeters is cancer, but if you stick with the rules and get it checked out, then you won't get it wrong. And the final one, the one that I try my best to get out and tease out of patients, but it's often very hard, is the evolution of the lesion. Is it changing? Is it new? When did you spot it? What's happened to it? Sadly, a lot of people don't know. They're usually on their backs or places that they haven't observed before, and over the long winter months, wearing hooded jumpers and sweaters, they don't see it until the summer when the sun's out and they take their tops off, and usually it's their other half or a relative or a friend who spots it. So I don't always have that information. The other thing that we sometimes use is this Glasgow checkpoint, which is fairly similar, and you can see the contrast. And you need to score 3 or more points. The ones with the asterisk is worth 2, and the others are worth 1. But it's the same principles really, in the sense that if there's a size, shape or color change or abnormality, you're going to score that. And then again, you can see based on the diameter, whether it's got symptoms, you're going to score as well. And indeed, those are the criteria used in general practice for 2-week wait referrals to dermatology for changing lesions. So locally, we tend to use the Glasgow 7-point checklist for our referrals, but it's the same principle. And then what happens? Well, what are you trying to do with that information? What you're trying to do really is get the mole that's ticking those boxes in for an assessment. It doesn't always mean that they're cancerous. A lot of these tick boxes actually end up being benign because we do have moles that are large and that have multiple colours. What's happening really is that you're referring them to have a look through our microscope. Normally, I would let you have a look through the microscope yourselves, but I can't today. And that's an example of a dermatoscope. And the dermatologists locally all are trained to spot features under this microscope that may be consistent with melanoma. Those machines cost about 900 to over £1,000, depending on the make and model and how fancy it is. So they're not cheap, but boy, are they a very useful piece of kit. It's the dermatologist's equivalent to a stethoscope. So I did tell you that not all big moles or multicolored moles are harmful. I'm sorry, I've got a truck coming by my window, so sorry if there's any interference there. There are some moles that you can completely be sure are safe, but maybe bigger than 7 millimeters, and may have other features that you might think, oh, that's a bit unusual. Some of you may even have this particular type of mole. And in particular, this one here, which is a congenital mole, is normally one that starts off life that's quite flat, usually before the age of 16. And over time, it evolves. And these moles change from infancy as a flat mole to mature adult life as a large fleshier mole, which you can see in the picture on the left. And indeed, on the right, this one has become raised. And some key features you might see when you look at it under the microscope include the hairs coming through it. We call these terminal hairs. You will also see there are these black dots sticking in the lesion, and these are called comedones, blackheads essentially within the mole. If you look really closely, I don't know how well it shows on your screen, you can see some blood vessels that look almost comma shaped. These are nicely named comma vessels for that reason. And particularly at the periphery, you can see that you've got a lot of round globules all clustered together. These globules form the basis and the base of this type of mole. These are very soft and fleshy when you touch them. They worry patients more than any other mole because they are raised, they grow, they catch a lot, and they can bleed and ooze and crust, ticking those boxes in the previous checklist. So the checklist isn't foolproof, but reassuringly, these are harmless, and the chances of these particular moles becoming cancerous is extremely small. So I can often reassure them, and people tend to have these removed because cosmetically they tend to grow on the face or in places where they catch and rub, for example, on bra straps or waistlines. Acquired nevi are usually flat nevi that start after the age of 16 and are very different and live a different life to those that you will get before this age. They tend not to evolve and form the fleshy raised moles that you saw in the last picture. And they tend to sit just like this on the skin and are flat and tend usually not to change. But a changing one of these, for me, is far more important than a changing one of the other type. This one again is on my arm. It hasn't changed, and I'm very reassured by that image. And what you can see when you look under the microscope is that it's got this sort of net-like appearance. There's lots of browns and a lot of clustering of pigment in the middle. That's quite normal for these. And as it spreads out like a web, you can see it's fading to the edge. That's normally what they look like under the microscope, and this is all very reassuring. But one of these that's changing, as I said, really does need a closer look. As an example here, when you look under the when you look at it from a distance first, you can see already this is looking abnormal, but clinically under the microscope, you can see how this mole has completely lost that network, which we saw in the other image. You can see there's absolutely no network at all. It's completely been obliterated, and in its place, there are shades of black, pink, and even in the top right-hand corner at 1, 2 o'clock, there's this sort of blue pigment. All of these are very worrying, and this indeed was a melanoma. So these acquired moles, they become more frequent as we age. So as you can see by the graph, at the age of 40, most people have up to 70 of these around their body. So what that means is from the ages of around 20 onwards, you're going to get more of these acquired nevi. So they do worry people. But as long as they're not changing and ticking the boxes, there's nothing to worry about, especially if they look like the image I showed you where you've got that network under the microscope. But interestingly, at 40, you've reached your maximum. You can see then the number tends to fall off. Now, these aren't the number of new moles you're going to get. This is the number of total moles on the body at any one time. So at 40, on average, you're going to have, if you counted, you'll have about 70 moles around your body, these flat ones, that is. But at 50, 60, 70, the number decreases. What does that tell us? Well, it tells us that these moles evolve by disappearing. They go. So essentially, that's what you'd expect. As we age, this type of mole regresses, disappears, and that's normal for these. However, what's really important then is this rule. If anyone over 40 starts to get more of these, or one in particular that is new and they're worried about it, it really does need a close look under the microscope. While it's not unusual and can happen, it shouldn't really happen as we get older, and so we do need to keep that just in the back of our minds. Is this a melanoma about to begin? So I would recommend when we hit 40 onwards, any new mole just needs a closer look. Here's a case study. This is a French student who came to see me who was here just for the summer, and he has a family history of melanoma, and he was really concerned about this mole on his shoulder, which I took a photo of. You've seen this image before, so you already know what this is. He was very concerned because it become more raised. He thinks he's had it a long time. And as you can see in the image, it's got that lovely round base and that soft raised center. So if we apply A, B, C, D, E to this, we can appreciate that if we remove the bit in the middle, it's fairly regular actually. It's normal borders, I can draw around it. The color seems the same all the way through. It was 6 millimeters, so just in limits, but it had changed. It said it was more raised and he'd had it a while. So based on that information, the only one that he was scoring on was evolution, E. And that's quite normal. I've told you about these moles because this is the raised fleshy one that he's had for a long time. The congenital mole, they evolve. So we don't need to send this one even though it's hitting the 2-week wait criteria. Although, and there you go, congenital mole. Right, so what I was more interested in was another one. Now just consciously look at his back. He's got lots and lots of moles, but I think you'll appreciate that there is one that stands out. And that was this one. So again, let's apply the A, B, C, D, E to it. You could argue it's a little bit symmetrical. If you draw a line across it from 1 o'clock to 7 o'clock, potentially you could fold it in half, it looks the same, but it's borderline. Again, the borders are a little bit projecting out. They're not clear cut, slightly irregular. It's definitely got more than 2 colors in it, or at least 2 colors even. And it was large, measuring 9 millimeters. He had no idea it was there, which is the usual story on the back. And this one clearly is ticking A, B, C, D, E rules. So what did we do? We sent this off for 2-week wait. Fortunately, this one was not melanoma. It was a dysplastic mole, which essentially is an irregular looking mole that does have a higher chance of transformation. So really, we caught this one nice and early. But what this does highlight is something I like to call the ugly duckling rule. In other words, if one is strikingly different from all the others, it probably is something that needs to come out, or at least looked under the microscope. So based on what I've just taught you, let's have a look at these, because some people do have a lot of moles. Some people have a lot of large moles, irregular shaped moles. And this particular case was an example of that. You can see on the back the collection of moles there. All of these were photographed under the microscope. They are all large, all bigger than 6 millimeters. You can appreciate that. When you look under the microscope, some are varying colors and shades. Some are fairly uniform all the way through. Some are asymmetrical. But generally speaking, if you looked at every single mole collectively, I think you'd agree that they all are fairly similar in their structures, colors, and shapes. They all look pretty much the same compared to each other. When you compare this one, was slightly different, the ugly duckling, and look at that under the microscope and compare, you can see the pattern here is completely different to all the other ones that would fulfill the 2-week wait criteria, A, B, C, D, E rules, and is strikingly different with different colors, shapes. It's lost that sort of haziness that all the others have, and the network as well. And this is the ugly duckling, and that one was melanoma. And this again brings in the concept of the signature nevus. Some people, unfortunately, have lots of moles, but their pattern is the same in each mole. It is their signature. And therefore, you can be reassured if you're seeing lots of the same looking moles, even though they're different shapes and sizes, with careful monitoring, just like we've done with this gentleman here. So the final point to say on melanomas is that you can get nodular types. And this is an example. So A, B, C, D, E can be extended to include E, F, G for this particular type. If a new mole is elevated, firm, and growing, it also needs to go via the 2-week wait. I just want to show you another case study. You may have seen people on the wards that have backs that look like these. Sometimes your consultant will ask a dermatological opinion, And sometimes patients come to see me worried about all these moles on their back. They catch, they bleed, they're huge. And if we look under the microscope in particular, you can see the largest one probably was that one and the one next to it. They've got that sort of roughness to the surface. And if we look closer under the microscopes, you can see how rough it is. They almost look a little bit stuck on the skin rather than in the skin as the moles are. And you can see even those black dots, just like the congenital nevi, these comedones, certainly around 12 o'clock in that picture, zoomed in. If we just cast our eye, comparing the one in the middle on this lady's back to the other two that we've seen, I think you can appreciate, even though the image is a little blurred, that it certainly does look like something sitting on it, whereas the other two look like they're in the skin. The skin on the surface is quite smooth and shiny, whereas the skin on the one in the middle is fairly rough. And that's because the moles originate deeper down in the skin and grow upwards, whereas these in the middle, and you can also compare it with the nodular ones, that sort of shiny look compared to the rough textured on the surface look, that's coming from deep within that mole. But these ones are all seborrheic warts, very common, harmless lesions. We see them all the time, and they're always confused with melanomas, or patients are concerned that they're melanomas. And thankfully, all you need to do is reassure. Can the NHS do anything about them? Usually, no. They are classed as a non-NHS removal lesion. In other words, you have to go privately and pay for these. Rarely do they get removed. You have to really argue that they are catching significantly, causing lots of problems, infections, that sort of thing. And you can remove them by freezing them, by shaving them off, curettage, cautery, that sort of procedure usually does the trick. Some other lesions you may have already seen on the wards or in some of your jobs, or even on yourselves or family members and not knowing what they are. So seborrheic keratosis we spoke about, but this is just another example of a crusty one sitting on the surface. They can look very different, and that's often why they get confused. You've got those red dotted capillaries, cherry hemangiomas, Campbell and Morgan spots, often in textbooks of old linked with liver disease. It's not true. I don't really see any association between liver and these. They're very common and frequent findings in older adults. I've even got one on my arm, and I promise I'm not a drinker. So the textbooks often misquote that. If you have a significant eruption acutely, that's slightly different. I would certainly check the liver then, but that often isn't the case. Other lesions that have been sent my way confused with melanomas or equivalent include molluscum in children. Now with these, you'll notice the central point of the lesion. We call this the umbilicated point. And they can sometimes appear as just one lesion and grow and get infected and can clearly cause confusion in diagnosis, but they're completely harmless and they go. Lentigos, like the gentleman's back of the hand there, these often are on sun exposed areas and sun damaged areas as well, completely harmless, but they can change. And then there are others such as this filiform wart. I quite like that microscopic image. It looks like he's got a nice head of hair. But these are the filiforms, and within each one of those, although it doesn't show so well, is a small streak of a blood vessel. And this picture is probably one of my prettiest and favourite pictures, but I do hope you've had your lunch already. This is another variant of a wart. It looks like something found at the bottom of the sea, but I think that's quite pretty, actually. And what you'll see and can see are collections of white globules, almost like frog spawn. And on each one, you can see it has the blood vessel feeding it. So this can be frozen or removed surgically. And finally, melanomas aren't the only skin cancers. We do have others. The most common by far is the basal cell carcinoma or rodent ulcer. They are slow growing, and typically they start off as a spot that never really heals. And they can start quite small and inconspicuous, maybe looking like sun damage or a bit of eczema, and over time progress into the more traditional BCC. As an example, you can see here, this is a raised nodular BCC. You've got that lovely blood vessel showing through. And another example here is one just on the side of this patient's face in the temple zone. Dermoscopically, you can see in the image those telangiectasia, which you may remember from medical school, those blood vessels going through. So this chap, he had a story of, I bang my head and it won't heal, doctor. He's had this for 5 years and it's growing on his forehead. He's got scabs, he's got this sort of pearliness to it. It looks almost sclerotic. And the dermoscopy, when you look under the microscope, you really can see those telangiectasia, those vessels going through. It looks like the River Thames, and lots of scabs and sort of orange scab, blood-stained scab, or erosion, as we call it, on the BCC. And that was a very complex basal cell. But again, the dermoscopy here is very helpful, and it's nice to see the features in it. Now, this squamous cell carcinoma, or one thing I should say about the basal cell is, generally speaking, they do not cause harm. They do not spread around the body. They do not metastasize. In other words, you can reassure the patient that they are harmless to them. It's extremely rare for them to do that, and which is why they're not sent on the 2-week wait. They need removing because, like you saw with this gentleman, they can get very large and problematic. So the sooner they're removed, in essence, the better. But they grow very slow, about 5 millimeters a year on average. So often they usually have to wait 3 or 4 months as they are not prioritized compared to the others. But the squamous cell certainly can, although again, very small numbers do metastasize. A small percentage do, and so they do need to be removed under the 2-week wait. And these are slightly different because they grow very quickly, starting maybe as there's maybe a dry bit of skin on a surface of maybe pink or red, which then grows and grows and becomes quite painful. And it's often pain that gives the game away. Sometimes it can just be a non-healing ulcer that's never going, but again, they are usually painful. And this is an example of one. And if you look under the microscope, you can see it's got that central cross and it's sat on a nodule, and that nodule is raised and painful. I don't know if any of you remember the sweet, the ice gem, but the ice gem sweet has that biscuit base with the icing sitting on top. SCCs tend to look like an uglier version of an ice gem. So this rule is patented by myself. I don't think any other dermatologist uses it, but it's the only way I remember it. An ice gem, the ice gem rule, if it's looking like an ice gem, it's an SCC till proven otherwise, 2-week wait. And that's, very briefly, lesions. So I'm going to, I'll ask questions at the end, if that's okay. And I'm going to move on to acne and see where we get to with acne. And if there's any more time, we'll do the last one. And the reason, like I said, is I want to talk about acne is because it is a condition that either gets neglected is the wrong word, but I guess mistreated. Patients are referred late quite often, or patients themselves don't think there's anything out there for them, and there really is. And diagnosing acne is usually quite straightforward, and you may have had it yourselves or know someone who's had it, but typically it's fairly easy to spot. The skin's quite greasy. You get lots of blackheads or comedones and whiteheads, which patients mistake as the pustules. It's not true. They're technically different. So I'll show you what I mean by a whitehead. They can get inflamed and red, as you can see in the skin here. And ultimately, what happens is this repeated process of inflammation leads to scarring and pigmentation. And that is the issue, because once it's scarred, there's nothing I can do for them. And it can be really disfiguring, which you will carry for the rest of your life. So what do I mean by these blackheads, whiteheads, closed and open comedones? Well, the open comedones, fairly straightforward. They are the blackheads. They're the ones that sometimes are quite satisfying to squeeze, and that hard bit of skin comes out, or keratin comes out. The closed ones, as you can see with the blue arrows, they are small little papules under the skin. You can see they're white. They essentially are the same, but the actual keratin hasn't reached the surface. Other areas you'll get acne are basically where there's oil secreting glands, and usually, other than the face, it will be the back, chest, shoulders, and upper arms. So it's always worth having a look there. They often tell you they've got it there anyway. And then this is worst case scenario. You can see the extremes to sort of mild scarring on the left and severe scarring on the right. And sadly, there's nothing the NHS can offer at this point. Privately, there may be stuff that can be done. It may not be perfect, but it does cost a lot of money, and a lot of patients can't afford to go down that route. So we want to prevent that. And how we treat it really depends on our understanding of acne. If we can understand what's going on, we can then target the treatment specifically to each type of acne, be it just simply blackhead acne or inflamed papules to the scarring, larger cystic acne. So what's happening? Well, essentially, the sebaceous gland unit is being sensitized and encouraged to grow by free-flowing androgens that often peak around our puberty time. And in females, you do get a spike around period time as well. So often females who get acne complain of worsening symptoms around their menstruation. And what happens is the gland swells up, excess oil is produced, hence the oily skin, and it becomes keratinized. Dead skin builds up and gets clogged up, which can result in a simple blackhead or whitehead. But this can then progress and get inflamed, which produces the inflamed papules. They can get infected because bugs on our skin then choose to use the oil as their food source, getting infected, which forms the pustules. And progressive inflammation results in deep cystic acne that can lead to the scarring. So essentially, it's the sebaceous unit that is responsible for the changes we see in acne. And therefore, when we treat it, we really want to try and treat the underlying activity to prevent acne from occurring in the first place. When we begin treating, we have to classify whether the skin condition is mild, moderate, or severe. A mild, moderate, or severe scale exists, but quite frankly, I very rarely use it. I really go on what the patients say, because some patients are really affected by their skin and there's not a lot to see. Whereas others have severe acne, and you're thinking, well, we really need to go for the big guns here, but they're not too bothered by it, and it surprises me. So really listen to the patient, find out what it is about their acne that gets to them, and treat it accordingly. But generally speaking, milder topical acne, such as just simple comedonal acne, can be treated topically. And there are varying different options. Benzoyl peroxide is very good. It comes in two different strips, 3 and 5%. And it works essentially as a bleach. It kills bugs. So it's really focusing on the bugs, the inflammatory type, the pustular type. And it will hopefully relieve some of that. So if you've got predominantly pustular type, this may be useful, but it can sting, it can cause irritation, and as it is a bleach, you have to warn them that it might stain their clothing. It's often applied in the evening before they go to bed, so lying down on their pillow overnight can lead to areas that depigment, so just warn them. You can add antibiotics into that, including erythromycin as an example, clindamycin, and they come in different forms. You may have heard of Zineret as one example. Again, focusing mostly on the bugs. Some antibiotics have anti-inflammatory properties, something that's relevant when we come to the tablet form. So they're focusing really on these, on their options, on numbers 4 and 5 there. But still, they're not very good at stopping the sebaceous gland from enlarging and producing excess oil. The retinoids, slightly different. They do focus on those glands. They do try and reduce the activity. And the only drug that really does that, azelaic acid also, is more of an anti-inflammatory. And these can be used as topical agents as well. They're very useful in all forms of mild and moderate acne. The retinoids we'll encounter again later on in their oral form, but particularly as a starting point, I tend to prescribe the retinoids combined with benzoyl peroxide to essentially target the gland enlargement, oil production, and the inflammation and the bugs. Epiduo is a license for that. Unfortunately, Isotrex can't get hold of at the moment. Females can also use the anti-androgenic pills, Diana and Yasmin. You may have heard about the issues with those and the increased risk of VTEs, but that risk is actually quite low, especially in the younger age group, as long as there's no contraindications. And if it's going to happen, it's going to happen quite early on, usually within the first 2 to 3 months. So if they're using it continually throughout their treatment, it's much safer rather than stop, start, stop, start. When we go on to the moderate form, we then assess whether the topicals have worked, and we can throw in some oral antibiotics, which are predominantly used here, not just to kill the bugs, of course, but as anti-inflammatory treatments. And you'll see in skin conditions that we tend to use antibiotics, not just for acne, but for other inflammatory conditions where infection doesn't cause the skin condition. The tetracyclines I find by far the best to use. They're usually once a day. It suits younger teenagers and adults who may not be used to swallowing tablets, who may more likely forget in their and also the other thing is that the size of the tablet's important. Lamicycline is quite a large tablet compared to erythromycin and doxycycline. But as I said, the benefits of the tetracyclines, it's once a day. Erythromycin is twice a day. Trimethoprim is a new regime, been around for a few years now, and as you know, UTI is usually what it's indicated for, but it seems to have an effect in acne and can be used up to 600 milligrams in split doses, so 2 or 3 times a day of the 200 milligram strength. But I often find that does affect the white cells and platelets, so you need to keep an eye on that. I have to say it's not my favorite regime. A lot of people do get side effects. I usually treat for about 4 months, and then I see if there's been a good response, then I continue for another 2 or 3, and then we'll try without. And when they stop, they continue the topicals, and if it's working and keeping things at bay, then that's great. But I have to be honest, I find that a lot of patients at this stage tend to need repeat courses of antibiotics and tend to get fed up. So are referred to me to consider the final option, which is Roaccutane. And Roaccutane has its advantages and disadvantages. There's been a lot of press about Roaccutane, but for me, it is the wonder drug. People with acne who go on it are amazed by how good it is. Even I've been on it, and I can vouch for it. It's fantastic. It completely cleared my acne up. And it works so well because it's the only drug that actually works by focusing on the gland and shrinking it down. It stops it producing that excess oil. So in effect, if you're stopping at the point 2, none of 3, 4, 5, and 6 can occur. So that's why it's very successful. And why don't we put everyone on it? Well, the reason is because there are some things that need to be considered. It's not for everyone who comes my way. There are some side effects that everyone needs to understand. Number 1, it's teratogenic. Females must use 2 forms of contraception, and I'm very strict on that, as are the auditors. That would include a pill or equivalent and condoms. They need to sign an agreement that they will not get pregnant. They have to have a pregnancy test once a month, so they are reviewed every month. It can affect mood in the literature. There is evidence to support this, although it isn't conclusive, and we therefore just take it cautiously, because my issue I have a lot of the time is people coming in to see me are down because of the way they look. Their skin is destroying their self-confidence and self-esteem, and actually I find quite the opposite. On most cases, their mood actually picks up as the improvements occur. So I treat that with caution and warn patients. We need some blood tests because it can affect kidneys, livers, and also can raise the cholesterol and sugar levels in individuals, although I haven't seen that too often. I very rarely see a problem in the bloods. Most of my patients are young and fit and healthy, so you'd expect that, but we do need to preempt a problem. And side effects, well, everyone does get one side effect, and that is dryness. Essentially, because it's stopping the oil production, the skin becomes dry, and as a result, you end up getting dry lips that can crack. The nose can get dry, which can cause nosebleeds. Eyes can get gritty. The skin generally feels rough and red. Most patients will just tolerate that because the benefits, i.e. their skin clearing up, are so obvious and exciting that they're very happy just to complete the course, which is usually 6 months. Every dermatologist does their own thing really when it comes to Roaccutane. Some will go for a 4-month course and go higher dose. Some will go for a slightly longer and start at a lower dose. But I here do a 6-month course, which tends to work quite well. So it is great. And I would suggest that if you see anyone with acne, be it in GP land or even on the street, or a relative who's got it severe, encourage them to get help. We'll see anyone for Roaccutane if it's severe scarring, if it hasn't responded to other treatment, particularly if there are psychosocial issues involved with their acne. And I'm very keen to see people with hormonal problems such as PCOS, because they don't often respond to the other treatments and do need Roaccutane straight out. So just some tips of when to refer to us, and don't be afraid to. I really don't deny people Roaccutane if they haven't any contraindications. It really does change lives, and I'll give you an example of that one. This lovely young lady came, and you can see how bad her skin was. She was one of those patients who wasn't too bothered by it, but she came because people were noticing, and she wanted some treatment for it. And straight away you can see, particularly on the picture on the right, how nasty and cystic it looks. There's probably even some scarring there. So we gave her Roaccutane over 6 months. I've only got 5 months of photos because unfortunately she didn't come for the last appointment. She'd moved away. But the right cheek, you can see each month how much it improves. Straight on, you can see the difference. The smile after 2 months even. And the other side that was so severe at the beginning, look at month 5 and compare it. It really does make a big difference. And the beauty about Roaccutane, in about 80% of cases, it stops acne completely. It doesn't come back to the same degree. So most people just need one course. There are those who do need more than one, and that's fine. They can come back to me. But the success rate is really high, which is another reason why it's such a great drug. So Roaccutane, we've got 10 minutes to cover the brief eczema and psoriasis, which I think we'll have time for, and then we'll have questions. So eczema and psoriasis, what do I want you to know for your final month and a half as an F2 on the wards and in your future careers? Well, how do we know the difference? Number one, it's important to diagnose it correctly because treatment is different, and also it has implications long term. So what's the difference here? Well, just glance at it yourself and just note the differences. There are some similarities, both are pink, but I think you'll appreciate that the one on the right has thicker scaling on the surface to that finer scale on the left. The one on the right on the elbow, the one on the left is in the skin creases. I think they're knees from the looks of it. I think they're knees. The other observation is that the rash on the right has a well-defined border. I can actually draw around it, whereas the rash on the left, I could give it a good go, but I'm very likely to miss bits. Eczema is on the left, psoriasis on the right. I think hopefully that was fairly obvious. And generally speaking, any itchy, scaly red rash that form patches like the ones on the left, or plaques, which are raised patches, always consider psoriasis and eczema as your differentials. And that just goes through what we've established. Now the Auschwitz sign, which is the last one on the list, I'm just going to show you. This is where you pick away at the scaling and you reveal these dotted vessels. And that's because the blood supply through the psoriasis plaque forms in these regular patterns through the way through. So eczema doesn't tend to do that unless you scratch. But a little pick off the scale and you should find these. So that might help you differentiate between the two. Now that one was fairly straightforward. So let's go on using those principles and very quickly look at this one. And just note the differences and ask yourself which one's eczema, which one's psoriasis, using those principles I've given you. And talking you through it, you can see that both actually this time are fairly well rounded, both are raised, both have thicker scale on them. So they both have that thick scale, but the difference clearly is that the one on the left has, again, irregular borders. I can't quite draw around it. There's bits dotted all the way around the periphery. The one on the right is definitely well defined. So It can be tricky, but the one on the left is a form of eczema known as discoid eczema, which is intensely itchy, whereas on the right, I think you've worked that one out, is going to be psoriasis. It can be harder yet. You can see these images of both raised papules, again, very itchy. And sometimes we don't know. Sometimes we need to biopsy. But some subtle clues here is one on the left has got a very small, what we would describe as guttate appearance. And you may have heard of guttate psoriasis, which you often will associate following a sore throat in the younger adult. And that may be in someone who has already known psoriasis, or maybe the first presentation. Whereas on the right, this was actually eczema, slightly more challenging, but again, it's slightly more diffuse, and the borders, while slightly more defined, are still slightly irregular, but the skin is quite fine and it is very itchy. So some tips to differentiate the two, just in the history, might help you work out which one is which in those difficult cases. Eczema tends to start in younger children, but can occur in any age, in fact. And there is often a family history, particularly with the atopic type. And on top of that, they may have hay fever and asthma. It can be triggered by stress and medications as well. And the skin is usually dry, and that's true of all types of eczema. It causes dryness, and you'll see some pictures in a bit. Psoriasis, on the other hand, I tend to find occurs in younger adults rather than children, or in middle-aged, and smoking and drinking can bring that on. I often find, particularly in hand and foot psoriasis, they smoke or drink. And there is, again, possible family history of psoriasis. Some patients might get some arthritic symptoms or being investigated for possible arthritic symptoms. Usually it's sausage fingers, swollen fingers. And sometimes I get them presenting as recurrent fungal infections where GPs have tried 3 or 4 different antifungals. Actually, it's not going away. And when I see them, I piece together the story and it turns out to be psoriasis. The location's really important. Eczema affects mostly the flexors, but again, can go anywhere, and the face. It doesn't copenarize. And what I mean by copenarize is it doesn't form insights of trauma. I'll show you pictures of that in a second. It does feel like sandpaper. It's rough to touch and can, in severe cases, cause the skin to crack or fissure and thicken up as a defense mechanism, which is called lichenification. Whereas psoriasis, when I see a patch, and I'm not sure if it is psoriasis or something else, I look at other places, in particular the scalp, around the buttock and the tummy button, the groins, the nails for nail changes, and this copenarizing phenomenon. I ask them if they have any scars and whether they've noticed any rashes on there. So here's an example of copenarization. Psoriasis isn't the only one to copenarize. Others can do it as well. Warts can do it. Vitiligo can do it. Lichen planus can do it. But on the left, you'll see the lower pictures of picture of fissures, and the one on the top is the thickened skin, which feels different to the soft normal skin, and that's lichenification. So for the next minute or two, we're just going to go through some case examples just to see if you can spot whether this is eczema psoriasis. So again, this chap has presented with hands that are very itchy, dry and flaky. And certainly, initially, we thought eczema. And then we had a look at his nails. And what you'll see in the picture on the left is how it just stops dead, right by the finger there. And if we have a look at those nails in a bit more detail in a second, I don't know if you can see, but you can see on the right, the yellowing, the oil staining. There are some pitting, those dots on the lower fingers there. And this ended up being psoriasis, which went with appropriate treatment. Similarly, this one on the ankle, you may see these on the wards, these hemosiderin type stains, scaliness, and if we zoom in a bit, you can see that scale and the brown pigment. And what this was is actually post-inflammatory hyperpigmentation, changes as a result of eczema being there, or venous eczema, and these stay after it's been treated. So this was no longer itchy, it was treated and gone, but the staining, because it's been there a long time, remains and can be permanent. So patients often say, it's not gone, doctor. Actually, it certainly has. Unfortunately, they're left with this marking, which may or may not go. And finally, we had this patient who came in who flummoxed us all. No idea, but it's got psoriatic look in the sense that it's sort of well-defined, round, raised. It was dry and scaly, it was itchy, and you can see even some of the scaling here. It turned out to be a weird form of psoriasis in the end, but we needed to biopsy this for confirmation. So sometimes when we just don't know, that is the next step. We proceed to a biopsy. However, a very red patient, this is probably one of the only few emergencies in dermatology that you may see present to the ward where they're bright red, and this is called erythroderma. It is a medical emergency. It's essentially skin failure, organ failure. You lose the ability to temperature regulate. You get dehydrated through the skin. Your kidneys can then knock off. Your heart then starts working harder, and essentially that can also lead to multi-organ failure if not assessed. It's often the result of drugs. That's probably when you're most likely to see it on the wards, but an acute flare-up of eczema or psoriasis can present this way, and very, very rare form of cutaneous lymphoma can do it too. So don't miss this one. And very briefly, just to finish, how do we manage it? Well, the same principles apply. We stop the itching, we reduce the inflammation, we remove dry, flaky skin, and we try and prevent chronic scarring from thickening of the skin and scratching. And the two main ingredients we need are, number one, moisturizer. In both conditions, particularly eczema, they've lost the ability to keep moisture in the skin. They are never going to get better if they don't moisturize, and it tends to be the hardest bit to do. Because it's not a tablet. It's easy with a tablet. You have to apply this just as many times as you brush your teeth, at least twice a day, but more if you can. And it is hard work. So I often find that's why things don't get better. And then we use steroids when it's acutely inflamed, often just topicals, and that usually does the trick if the regime is good enough, particularly for the mild and moderate cases. There are a range of moisturizers. The general rules are it doesn't matter which one you use as long as the patient likes to use them. And here are just some of the examples that they can get from the shops. But the general principles are use them as often as possible. Just choose one the patient will use. And during a flare, I would suggest a greasy one or an ointment. Why? Well, creams and lotions tend to have things in them that can make the skin more irritated. So they often complain it stings when it goes on or it's not working. An ointment is therefore the best one to use in those examples. The problem is it's so greasy and messy, a lot of patients don't like using them. But the principle is to get the skin hydrated. They are by far the best ones to do that. And when it's calm, they can switch back to their creams if they prefer. It is less messy. Now, this is a bit out of date. Consider bath oil. Well, that's now been removed from NICE guidance. We don't need to do that. There's no evidence it works, so ignore that point. But a soap substitute is useful. In other words, some moisturizers, particularly the dermal one up there and the QV, have a soap range. And it helps to moisturize the skin and clean the skin, and it stops them using products with perfumes in that can irritate the skin more. When it comes to steroids, generally speaking, it's the same principles. And on the left, you can see just some of the common steroids I use in strength order, going from the weakest hydrocortisone through to the strongest Dermavate. And in psoriasis, we can also use vitamin D analogues. And you may have heard of Dovobet, which is a combination of these plus betamethasone. Again, general principles are ointments are best prescribed in all cases for the reasons I said before. And I would apply them after the moisturizer. Some dermatologists say before, but I prefer it after because the skin can be prepared with the moisturizer. It soaks in better. And also, if you put it the other way around, when you then go and put your moisturizer on, you can rub the steroid all over the body in places you don't really want it to go. And don't be scared of steroids. People are scared. They thin the skin, apparently. Well, yes, they can if you use them every day for months and months on end. But this is a chronic condition. Asthma sufferers use steroid inhalers all the time. People with polymyalgia are on steroids for years. The skin will do its job, and it will only get better if it's treated appropriately. And if we aren't treating with enough steroid, what's going to happen is it keeps flaring up. So you then use even more steroid. And actually what we want to do is hit it hard, wean it down, and keep them on a nice maintenance regime so things can stay calm. And that's in the NICE guidance. So that's on NICE, and you can look that up as well. So there are lots of different regimes. Each dermatologist has their own. But generally speaking, I might start off with something like this. Plenty of moisturizer in both conditions. And with regard to eczema, I might suggest a moderate, mild steroid, perhaps in when the eczema is not too bad for flare-ups, once or twice a week to start, then weaning down each week until we've done maybe 3 or 4 weeks and stop. And that's just one example that I might use in mild to moderate eczema. For more severe or widespread, I might go a little longer than that. Similarly, with psoriasis, I tend to use the product Dovabet in its foam form called Enstellar, which seems to work better than the gel and ointment product. And this can be used every day until the plaques are resolved. It tends to be about 4 weeks, and then they can use it twice a week as maintenance. The plaques are thick, so a bit of thinning there isn't going to cause an issue. And the final thing really is when we are trying to keep things under control, I tend to suggest using either a steroid or the Dovabet once or twice a week in those problematic zones. But we can introduce these products, Protopic and Elidel. These are calcineurin inhibitors, anti-inflammatory, and are used as steroid-sparing agents on the skin to control eczema and psoriasis in areas that it continually comes back. Really good for the face, where we're a bit more wary about steroid use. And they work very well. The Protopic comes in 2 strengths. The strong one, 0.1, is equivalent to a good strong steroid like Betanavate or Elicon. The weaker one, the 0.03, equivalent to potentially around the Umavate level, and the Elidel is roughly the equivalent strength to hydrocortisone. They aren't great for flare-ups, and the reason is because applying these on a flare-up will cause quite a lot of irritation and stinging, and patients won't like it. So we still need steroids initially when everything's flared up. And they can be used once a day, the milder ones twice a day in those problematic areas. And you can use those as the maintenance regime once or twice a week if need be too. The only one last bit of advice before we finish is don't give oral steroids in psoriasis unless it's through specialist advice, because while they'll get better, if you give them steroids and stop, it can erupt into this pustular rash, pustular psoriasis, which is another one of those dermatological emergencies and can be really nasty and widespread. And sometimes they need admission with this one too. So just be wary when you're giving oral steroids. And that is my talk complete. I have stopped it at managing eczema and psoriasis simply at the GP side of things. You will obviously know that if all of that fails, you refer to dermatology, and then they can do other things like phototherapy, immunosuppressants, and biologics. But that's for a secondary care talk. So I hope that was useful. Don't be scared of steroids. Refer acne early, and remember those little tips I gave you for those moles. And hopefully you found that useful. So we are done. I can now stop sharing. If anyone's got any questions, please feel free to write them down now and I'll answer them. Someone's writing. No question. Oh, you are welcome. All right, if no one's got any questions, I'm done. So thank you very much for listening. Oh, Mary has.